Okay, so good morning everybody. We're going to do a little quiz on coarctation of the aorta, which as you all know is a narrowing of the aorta, and it can be at any level. Now, let me ask you first question. If you do not treat a coarctation of the aorta, how many percentage of patients will die before the age of 50? And they die from heart failure, from endocarditis, from aortic rupture, from hypertension. So how many percentage of patients you think will die before the age of 50? 10%, 50%, 90%, 100%. Okay, everyone's still waking up, I see. So 90% will die before the age of 50. And that means you're really shortening the lifespan of patients with coarctation, so they don't get to be grandfathers. And as you can see, they die from a variety of things, including endocarditis or aortic rupture or hypertension. Now, do you know when surgical treatment was first done for coarctation? Roughly in which year? And when was balloon angioplasty still done? Recently done. Which year was balloon angioplasty done? Which year was surgical treatment done? And you'll see that even though they've been around now for quite a long time, there's still a lot of discussion on what is the best therapeutic approach. So anyone, when was surgical treatment first done? Roughly in which year? What happened? Are you guys? Okay, so surgical treatment was first done in 1944. So as you can see, that's more than 60, 70 years ago. So we've had management of coarctation for that long. And balloon angioplasty in 1982. So that's 30 years we've had balloon angioplasty. And we still debate on what is the best therapeutic approach, which just goes to show that in science things constantly evolve. But the good thing is that coarctation treatment has been around now for between 30 to 60 years. So it's not a new treatment, and really these 90% of patients dying before the age of 50 should not be happening anymore, and most of them get treated at a very young age. Now, if you make a diagnosis of coarctation, does it mean you have to intervene? And what are the indications for intervention in coarctation? When would you go in and fix a coarctation? Do you fix all coarctations? Okay, first question. Okay, so if you make a diagnosis, doesn't mean you have to intervene necessarily, right? That's first. So what are your indications for coarctation repair or fixing a coarctation? What indications would you send the patient for some treatment? You can type them in. What are the indications for intervention for coarctation? Okay, one is symptomatic, one is LV dysfunction. So symptomatic LV dysfunction would be together. What else? Which coarcs would you not operate on, right? So if you had a mild coarc, asymptomatic, gradient less than 20, you wouldn't operate. So your indications to intervene are if you have a gradient greater than or equal to 20 millimeters in the cath lab. So that means if you have asymptomatic patient, on echo you have a mild coarc, gradient is let us say 15 millimeters or 20 millimeters, you don't need to intervene. It's only if in the cath lab the gradient is more than 20, you're going to do something. Second indication to intervene is hypertension. So if a patient has upper limb hypertension, that is an indication for intervention. And of course symptoms. So any patient is symptomatic, has LV dysfunction, any symptoms, you're going to intervene. But any patient is hypertensive, you're going to intervene. And the other one, please remember, is if you have a gradient greater than or equal to 20 in the cath lab. That is an indication for intervention. So when you say, okay, I made a diagnosis of coarc, but I don't need to intervene, those would be asymptomatic patients with mild coarctation with gradients less than 20 millimeters and no upper limb hypertension. Right? So that small subgroup of patients where the blood pressure gradient you take is less than 20, you check in the upper arm, there's no hypertension. You look on echo, it's a very mild narrowing. There's no PDA, so you're underestimating your gradient. LV function is normal. Patient is fine. That small subset, you don't have to intervene. Almost all other coarctations, you need to intervene. Okay, all clear on this. So what are the interventions? Now let us say you have a neonate. he was born, pediatrician felt femoral pulses were weak, and he's really sick. His perfusion is poor, he's acidotic, he gets shifted to your unit, you're going to put him on the ventilator. So what is the first thing you're going to do? Okay, you said surgical, but before surgical, what are you going to do with this patient? Prostaglandin. So not to forget that your first intervention really is prostaglandin to stabilize this patient. Then you're going to decide, okay, do I need surgical therapy or balloon therapy? And what would you go for in a neonate? What kind of therapy? And I think you answered there, surgical. That's right, the surgical therapy. Having said that, there is a small group of people who feel that even in neonates and infants you can balloon. If they restenose, 50% will restenose, you can balloon again. So, but the vast majority of centers would go for surgical therapy in a neonate. Now, why surgery in a neonate? Why not ballooning in a neonate? Why would you go for surgery in a neonate? And surgery is the right answer, but why surgery and why not ballooning? Okay, so there is an increased incidence of recoarctation with surgical, right? So there's a recurrence after ballooning, that's right. And why is there a recurrence? Because in a neonate you have a lot of ductal tissue. And if you balloon it, the ductal tissue is still there, and over time that ductal tissue narrows down and, again. In surgery, on the other hand, you remove all that ductal tissue. So the incidence of restenosis is 50% if you balloon it, and much lower if you do surgical therapy. The second issue is the duct, because the duct may be open in a neonate. So when you balloon it, the duct stays open. But surgically, you can close off the duct and remove the duct at the same time. So in a neonate, we choose surgical because ductal tissue is removed, and therefore recurrence after intervention will be lower. Now, can you name in one shot 4 surgical procedures for coarctation repair? And then we'll go over each with advantages and disadvantages. So name 4 surgical procedures you know, surgical for coarctation. Okay, so let's see here. Resection and end-to-end subclavian patch. Okay, so that's 2. Prosthetic patch 3. What's the 4th? 4th one is bypass graft. That's right. So resection and end-to-end, subclavian patch, prosthetic patch, and the bypass graft. And we'll go over what are advantages of each. So this is end-to-end. You see the picture here, you basically would cut one end, and join the two together. Now, what are the advantages of end-to-end and what are the disadvantages? What are the advantages of an end-to-end? So one advantage we said is you can remove ductal tissue, right, and then connect it. What is the disadvantage? Yes, the advantage is resecting ductal tissue. Disadvantage? Any disadvantages of end-to-end resection? And think of all your disadvantages really of, in general, of coarc repair, of course. So it's not suitable for long segment, that's right. So it's good for short segment, right? So that's again an advantage. It's good for short segment, and you're going to remove all the ductal tissue, and you're not putting any prosthetic material. These are all the advantages. Disadvantages are not suitable for long segment. You get scarring in restenosis because they're pulling it together and putting this long suture line. Spinal arteries can be affected because you're doing a lot of dissection. So these are the advantages and disadvantages of end-to-end. Okay, next you had mentioned subclavian flap, right? And so you can see this picture. You've got basically what you're doing is you've got the narrowing. You're cutting through the narrowing, you're cutting into the subclavian artery, then you're turning the subclavian artery down. So the subclavian artery here is now becoming a part of the wall of the aorta, right? So you see the first picture on your left here. You've got the subclavian artery, you tie it off higher off, you turn it down, and you attach it to the aorta. So this is the subclavian flap. Now what are the advantages of subclavian flap and what are the disadvantages? So for long segment, preferred in neonates. Okay, so it can be used for long segment because that whole subclavian can get turned downwards. It It can only be used in neonates actually, right? Why can you not? It's non-prosthetic material again, so that that can grow. Other advantages? What are the disadvantages? What is the disadvantage of a subclavian flap arterioplasty? So the disadvantage is you are using the subclavian flap. Now, in which age group do you use subclavian flap typically? Yes, upper limb growth is affected, that's right. So in which age group do you use subclavian flap? Only in neonates, right? And the reason is because of this disadvantage. Because when you, let me just put here, when you sacrifice a major artery to the left arm, right? In a neonate, what happens? A lot of collateral flow can develop very fast. And so they actually tolerate it very well. However, the disadvantage is you will get poor growth of that extremity. So the limb would be compromised if you did a subclavian flap in say an older child or an adult. So we would never do it in that age group. So in a neonate, typically they'll get a lot of collateral circulation, and so it's okay. So sacrifice of a major artery to the left arm resulting in poor growth of that extremity over time is the main disadvantage. Advantage is you actually having native tissue. You don't have these circumferential sutures. You saw an end-to-end is circumferential, so they can restenose, they can scar. Here, look at the suture line, it's down this way, right? So this allows for better growth of that whole involved area over time. And so your restenosis is very low, your growth of that area over time is much better. Okay, all clear on that. This is a patch aortoplasty, where you're taking a prosthetic material and using it to patch it open. Kind of like your tetralogy of fellow, where you patch your RVOT with a patch, right? Similarly, you patch the arch. So what are the advantages of a patch aortoplasty? And what are the disadvantages? Name one important advantage. Okay, for long segments. What's an important disadvantage? What's an important disadvantage? What is the main disadvantage of patch aortoplasty? Why it has been given up? That's right, aneurysm formation. Right. So the advantage of patch aortoplasty, now we said in a neonate, is when you have long segment coarc, subclavian flap is very good, right? But we also said you cannot do subclavian flap in an older child. So what do you do in an older child with long segment coarc? There are very few choices. So one of the choices is patch aortoplasty. So long segment coarc in an older child or adult, patch aortoplasty. Typically here you see you're not doing too much of dissection and all that. You're not having to cut the whole, remove the aorta, so the spinal arteries get saved. So your paralysis issues are much less. You're also leaving a part of the native aorta here. Here's the patch, here's the native aorta. So the native aorta can grow. Disadvantages, as you said, main disadvantage is aneurysm, and that's why patch aortoplasty is not commonly done anymore. Okay. Bypass graft, you said, was the fourth type, and you can see here where it's gone from ascending to descending. You're basically taking a graft and essentially bypassing the segment. What is the advantage of a bypass graft? Which situations do you use a bypass graft in? Calcutta very quiet today. So hypoplasia of the arch, okay, so if the whole ascending aorta is somewhere, if the transverse arch is small and you want to bypass it, what else? If you have very long segment, right, and you really, even a patch you're not able to do. So it bridges ascending and descending aorta. It's good for very long segments, but the disadvantage is that the prosthetic material does not grow. And over time, this thing becomes narrow and calcified, and you get gradients in it, and you have to typically replace the bypass graft. In adults, it's okay because you're putting it once. It's a large bypass graft. The patient is also older. In pediatric population, because it doesn't grow as the child grows, you may have to replace it. Unlike in, let's say, a subclavian flap or an end-to-end where you can go in and balloon it later. Here you're talking about a second surgery where there's a lot of scarring and calcification. Is anticoagulation required? No, Not that I know of, because it's a high pressure system. The ascending aorta, you've got a high systolic and diastolic pressure, so typically clot doesn't form, unlike in a fontan. The same thing on the other side, on the right side of the heart, you would put anticoagulation because it's a low flow system. So typically we don't keep them on it. Some people will keep them on aspirin just to be on the safe side, but it's not necessarily 100% because it's a high flow state. Now we talked about the 4 types of surgeries. We'll just briefly discuss beta blockers. And the real aim of beta blockers pre-operatively, before surgery, is to reduce some of the upper extremity hypertension. Secondly, it is also to basically prevent, or when you have that dissection, when you dissect around the aorta, a lot of sympathetic nervous system stimulation, and you get a lot of catecholamine release, and you have hypertension. So you want to prevent that kind of sympathetic release in the operating room, and you want to prevent post-operative paradoxical hypertension. So you give beta blockers before. But the thing to remember is that you shouldn't, give over vigorous attempts. In the sense, you're not going to, don't try and achieve a normal BP, because then what is happening? Your lower body perfusion is dependent upon your pushing pressure from above, right? If you lower the upper limb blood pressure, hardly anything will get past the coarct, and you will have inadequate lower body perfusion. So you're giving beta blockers prior to surgery to reduce the severity of post-op hypertension, okay? But it shouldn't be overly aggressive. It should just be enough to slightly reduce the upper extremity hypertension. Look at your ECG and make sure your heart rate is slowed a bit, but don't try to achieve a normal upper extremity BP pre-operatively. Okay, all clear on this? So what is the best drug in the ICU for high blood pressure post-coarct repair? For paradoxical hypertension, what is the best drug in the ICU? And why do we keep these patients NCO? So esmolol, all agree with that? Yes, short-acting beta blocker, very good in the ICU. You can turn it on, you can turn it off, depending upon the blood pressure. So esmolol is the best drug for post-coarct paradoxical hypertension. Why do we keep these patients NCO? Nil for orally for 72 hours, you'll see on all the sheets. Because they can have, why do they have mesenteric ischemia? Because you have clamped, right? GI ischemia, that's right. And because you have clamped the aorta, right, for maybe 10 minutes, 20 minutes, depending on your surgeon. Very quick surgeon, he clamps and finishes in 6 minutes. Slower surgeon, he may clamp for 25 minutes. So what's happening? You have all that period of low perfusion to your gut and to your lower body. Suddenly, when you get the clamp is unreleased, what happens? So now you've had a period of ischemia. Now you release the clamp. Suddenly he gets now the coarct is relieved. Now all this blood is going into the gut. Now what happens? You get reperfusion injury. And that's why you keep them. So it's not just ischemia, it's ischemia followed by reperfusion injury. So therefore, the kidney, the gut, the mesentery, all of this can suffer from this. And therefore, at least for the gut, we can't do much for the kidney part. We keep it nil for orally so that the gut is rested. It recovers from this injury, and then you start giving it something that it has to digest and do something with. Otherwise, you run a risk of necrotizing enterocolitis. Good. Now we'll just discuss some of the pros and cons of surgical versus balloon angioplasty. Now with surgical therapy, the mortality is very low, less than 2%. There still is some morbidity. One is pain, one is infection, you can bleed, you all know you can get spinal cord ischemia, and you can get paradoxical hypertension. Now even with surgery, there is a restenosis rate, varies from 5 to 30%. Typically they say around 10 to 20% is the restenosis rate when the kids are smaller. In older teenagers and adults, it's hardly 2 or 3% is the restenosis rate. It's quite low. Now one of the things that people would use to beat upon angioplasty was aneurysm. That, oh, if you do angioplasty, you're going to get an aneurysm. If you do surgery, you're not going to get an aneurysm. But actually, they've done MRIs of patients who are post-surgical and found that even those patients develop aneurysm. So really, it's not that surgery or angioplasty has they both have a risk of aneurysm. So that is quite equivalent. So they both have a risk of aneurysm. Surgery also has a restenosis rate, and there is a certain morbidity with surgery, especially in adolescents, adults, of spinal cord ischemia, paradoxical hypertension, lot of bleeding, lot of pain because you're doing a thoracotomy. And therefore, there was a search for alternatives. Now, one of the alternatives, as we saw in 1984, was balloon angioplasty. And let me ask you all, how does balloon angioplasty act? When you take a balloon and you do balloon angioplasty, what is the mechanism of action? Tear of intima and media, medial tear, okay. So essentially, that's right, it is, and ideally you want to only tear the intima. You do land up tearing media also, and you don't want to get into adventitia. So the way it acts is by tearing the vessel wall. It's tearing the intima and the media. Now you need to know this, which is a minor flap. Minor flap is less than 1/4 of the circumference of aorta. More than 1/4 of the circumference would be called a major flap. And after every coarct repair, do you see a flap? Do you see like a little flap of tissue near the coarctation? Do you get worried? Do you not get worried when you see a flap? So if you see a flap, what are you going to do? And the answer is that flaps will occur, right? Because the mechanism of balloon angioplasty is to tear the vessel wall. So in almost all the cases, you will have a flap. In fact, if you don't have a flap, it means you haven't really torn the vessel wall. The good news is that even significant tears, even major tears, and you see here this IVIS findings, intravascular ultrasound, 80% had a major dissection. But even significant tears will heal partly or completely with remodeling. But part of the problem is sometimes if you have a very significant tear, that area is weak and it may go on to develop aneurysm later. Scarring occurs, you may get restenosis later. And so the mechanism of balloon angioplasty is also the same reason it has certain issues in the long term. So coarct angioplasty before and after, as you all know. Now there are two types of coarct essentially, right? Recurrent coarct and native coarct. What is a native coarctation? What do you understand by native coarctation? Anyone? What is native coarct? So coarct before any intervention, right? Before any surgery or before any ballooning. Recurrent coarct is a coarct that is, yeah, so that's right. Untouched coarct presenting for first time is a native coarctation. Recurrent coarct is a coarct that has had some kind of intervention and the coarct has come back. Now in a recurrent coarctation, essentially there is scar tissue. So surgical repair is technically a little difficult because if the patient has already had surgery, now there's scar tissue. You want to go in and do surgery again, it's a little technically difficult. So for recurrent coarct, say patient had surgery before or balloon before, balloon angioplasty for a recurrent coarct is well accepted. There's no controversy in this. So patient has surgery, now has coarct, you will go back in and balloon it. Native coarct is more controversial. Now, angioplasty actually has a good success rate, 70 to 90% when you balloon a native coarct. But what is the disadvantage of angioplasty in a native coarct? Recurrent coarct, we all agree, go in and balloon. Native coarct, what is the downside? Why is it controversial? Okay, one is recurrence. Anything else apart from recurrence? So as we discussed, right, aneurysm. What are you doing with angioplasty? You are tearing the intima and media. So there is a chance of aneurysm, and a lot of people will argue that it's actually higher than surgery, even though there are studies showing it's equivalent. Smaller case femoral artery problems and of course restenosis. So these are the issues with native coarctation. Now, when in older children, right, so say you have an 8-year-old or 10-year-old, native coarct is quite widely accepted. The results, good results, 90% success, it's relatively safe. Restenosis is 7 to 12%. Neonates is another issue. And as we discussed, there's a risk of restenosis, so a lot of people will prefer surgery. But, and then if it recurs, you balloon it again. But there's one more camp which says, let me balloon and then balloon again. right? But I think in neonates and infants, most people agree surgery. If it restenosis, then balloon. Older children, and most centers will agree you can do balloon angioplasty for native coarcts. Now, what is an aneurysm? What is your definition of an aneurysm? This is an example of an aneurysm. Okay, and you can see here after angioplasty is developed an aneurysm. And earlier there was a much higher risk of aneurysm, up to 40%. And that's why angioplasty got a bit of a bad reputation. But now the ways you can prevent aneurysms are shorten your inflation time and use less long balloons, use shorter balloons, and don't oversize. So if you don't oversize, you don't do prolonged inflation, you can actually reduce your risk of aneurysm to 5%. So you have to be a little conservative when you're doing a coarc. You don't go crazy with ballooning. So aneurysm, yes, you say 1.5 times the normal. Now let me ask you, in a coarc situation, what is normal? Where do you take the normal? Which part of the arch? Because say you had a post-aortic dilation, is that normal? How do you define in a coarc 1.5 times what? In a coarc situation. And the answer is it's 1.5 times the aorta at the level of the diaphragm. Because that is going to be what you take. It's the same way you use for your balloon sizing, right? You take the aorta at the level of the diaphragm and you're not going to exceed that for your coarctoplasty. Same if an aneurysm would be 1.5 times the aorta at the level of the diaphragm. Okay. So risk for aneurysm with after angioplasty was higher. We as cardiologists can avoid this risk by using accurate balloon sizing, not oversizing, not using very long balloons that we don't need. You don't need to tear the media of the normal aorta, so shorter balloons, and not having very prolonged inflation times. And the risk of aneurysm can come down to less than 5%, which is as good as surgical. So you all said native coarc, you don't want to do angioplasty because there's a recurrence. So what is that recurrence rate after balloon angioplasty? And what are the risk factors? This is what we need to know, right? We tell a family, see, I don't want to do angioplasty because it's going to recur. He's going to ask you, what is the chance of recurrence? So what is the restenosis rate after balloon angioplasty? And which patients will have, what is the risk factors? So, okay, Vikas says 50%, and that's right, in neonates, 50%. What about, say, in a 10-year-old? What is the, in older children, it would be less. What are the risk factors? So, restenosis greatest in neonates and infants, 50%. Older children, 7 to 12%, similar to surgery. Risk factors for restenosis. Okay, one risk factor is age. Neonates would have higher. Anything else apart from age? Anything about the anatomy itself which is a risk factor? So when you see that on an angio, you say, oh, I'll balloon it, but you know what, this kid is going to have a higher chance of restenosis. And then you need to put that in the file and tell the parents that, look, he may re-narrow, you keep coming back, we may have to balloon again. Okay, long segments. Long segment, you may not do angioplasty, right? Anything else? And this is something you all should read this article. It was in JACC, where they looked at some of the risk factors. So younger age was one, less than 1 year. Ischemic hypoplasia. If your isthmus is narrow, right, you are only ballooning the coarct part. If the isthmus is narrow, then you may not have, you may have recurrence much faster. Then the third was, if the area was very narrow, like let's say it's only less than 3.5 millimeters, and even after you balloon it less than 6 mm. So very, you can say small area or a very tight coarct at a higher restenosis rate. So young age, ischemic hypoplasia and smallish coarcts all have a higher restenosis rate after angioplasty. Now, oops, let's see this. Balloon angioplasty versus surgery. Okay. Oops, it's all coming. Anyway, what are the risks? The risks of balloon angioplasty, we said one is femoral artery occlusion. The surgery, we don't have that. But nowadays, you're getting low-profile pediatric balloons. All your Taisha-2s, they're all going to 5 French, 4 French. So this risk has really come down. What are the advantages of balloon angioplasty versus surgery? Can you name 3 advantages? See advantages of balloon angioplasty versus surgery. Disadvantage, we said femoral artery occlusion, maybe higher incidence of aneurysm. Okay, so no scar is one advantage. What else? Advantages of balloon angioplasty versus surgery. Everybody didn't read and come. So no scar, right? Because there's no thoracotomy. No scar means no pain, right? No spinal cord ischemia. Remember, you're not dissecting around, you're going inside the aorta, you're not going anywhere near sympathetic nervous system. The chances of paradoxical hypertension are much lower. You're not cutting around, you're not hitting a spinal artery, there's no chance of spinal cord ischemia when you do a balloon angioplasty. You're not using a subclavian artery, there's no impaired arm growth, and as you said, there's no thoracotomy, so there's no scar and there's less pain. So the main advantages of balloon angioplasty that you need to remember are these: avoidance of thoracotomy, no spinal cord ischemia, less paradoxical hypertension. And of course, compared to subclavian stuff, no arm issues. So that doesn't apply to the others. So we've given you the advantages of balloon angioplasty. So what are the indications for surgery? If balloon angioplasty is so fantastic, how come we still need surgery? What are the indications in today's day and age, 60 years later, for surgery for coarctation of the aorta? Okay, so one indication is neonates and infants. That's right. Infants, in fact, I would just say early infancy, like a 10-month-old or a 9-month-old or an 8-month-old, you could also balloon. So let's say neonate, long segment, that's right. Anything else? Apart from long segment and neonate, any other indication for surgery? Think of something else going on in the heart. Yes, associated intracardiac lesions. So neonates and young infants, associated lesions. Like if the patient has a large VSD, you need to close the VSD. You might as well do the surgical coarct at the same sitting. If the patient needs a CA band along with a coarct repair. If the patient is having a coarct along with you're doing some single ventricle procedure, whatever it may be, associated lesions requiring surgery. Third is transverse arch and isthmal tubular hypoplasia, which will go with your long segment. If the whole thing is narrow and you just balloon one part of it, it's definitely going to re-narrow. So in that situation, you need to patch open that whole long segment hypoplasia. So these are the indications for surgery. All clear on that? Right? So there is now, apart from angioplasty and surgery, there is a new advance, which is stents. This is really used in older children and adults, and it's used to open up the arch, again in the cath lab. And even what are stents made of? What is the material that stents are made of? So platinum is one, cheap platinum stents, but more common stainless steel. Right, so stainless steel is cheaper, the platinum stents are more expensive, so either stainless steel or platinum. What are the advantages of stents? What are the advantages of stents you think versus surgery, versus angioplasty? Versus surgery, okay, again there's no thoracotomy, there's no paradoxical hypertension, there's no spinal cord ischemia. Versus angioplasty. Okay, less chance of aneurysm, because why is there a less chance of aneurysm? You have a tear, but you're putting the flap back, right? You're holding the flap against the wall. So there's no chance of further damage occurring with high pressure because the wall is weak. You've actually made the wall strong. So restenosis rates are lower, yes, it can be redilated. So these are all big advantages. We saw with angioplasty, big issue, one issue was restenosis, one issue with aneurysm. So with stents, there's no restenosis or very little. There's no aneurysm formation. You can also use a stent for tubular or long segment narrowing, which balloon angioplasty cannot. Balloon angioplasty is good if it's short segment. If you have a longer segment, stent is a better option. And the good thing is it can be re-expanded at a later age, even after growth. Even after the patient grows, you can re-expand it. So that's about stents. This is just one example. Narrowing, this is the mark of pigtail. You see that here on the left with the dot. So using that marker pigtail, you can measure your size and then you again choose your stent size. You don't want to be bigger than your transverse arch proximally and the descending aorta at the level of the diaphragm. You don't use your post-stenotic dilation to decide your stent size. So I think we'll end, it's almost, we have 5 minutes left. So which intervention for what? Very quickly recap. Subclavian flap in which age group? Neonate. Okay, now you are not going to use it in old kids. Next question, long segment coarct. What are your options for long segment coarctation? Long segment coarct, name all your options. That's one. Bypass graft is one. What else? Stent is one. What else? Name all three in a row. So your patch aortoplasty. Remember we said patch aortoplasty could also be used for long segment. So long segment coarct, your options are patch aortoplasty or a jump graft or stenting. That's right. 3-year-old with a discrete coarctation, what are you going to do? Okay, all agree balloon angioplasty. Some centers would do surgery, but that's okay. Balloon angioplasty is the right answer. Newborn with coarctation, what are you going to do? You're going to do surgery, prostaglandin and surgery. Few proponents for balloon followed by balloon. So, you may get someone who actually believes in that. And there are a few centers in India where they did balloon, when it restenosis, balloon again. So just keep that in the back of your mind. Your examiner is pushing you on that. And recurrent coarctation, what are you going to do? Recurrent coarctation. Balloon, all agree with that. That's right, balloon angioplasty. Common protocol, and this is a common protocol which is really most places would agree on this. Neonates and infants with PDA, we do, as you said, surgery. Older infants and young children, what would you do? Older infants, young children with native coarct. Older infants, young children, you could balloon. Older children and adults with native coarct, what are your options? What are your options for adults? So remember, yes, you need to put in stent. That's good. Ballooning or stenting is your option as you become older. Recurrent coarctation, what is your option? Balloon. Or again, remember stent if it's an older patient. So keep in mind, neonate surgery. Older infants, young children, balloon. Older, like adolescents, adults, balloon or stent. It keeps changing. Recurrent coarct, depending on your age group, either angioplasty or angioplasty with stenting. Associated lesions, what do you do? Surgery. That's right. So I think with that we'll end. We've covered kind of management of coarct. And if there any questions from anyone?